with 3 decades of healthcare leadership, and he is now the current, now in his current role as the Chief Executive Officer at Clinton Memorial Hospital, Regional Health System. He's assumed the role. He's been in the role for just over a year, and he's been doing a lot of transformative change there in Clinton Memorial. And in a previous role, he was he was the leader of Westchester Hospital in Westchester, Ohio, just down the road to my house. Him and his team have taken care of my family because that's our healthcare provider at Westchester Hospital. So he's, whenever I would go to Westchester Hospital, if I had any issue or I had a good experience, Tom knows, I would send him an email and I'd say, Tom, just to let you know, these people are awesome. And we had a great experience, and we were in and out really efficiently, and he and the other leaders at Westchester Hospital would always respond and say, thank you so much for the feedback, and he is somebody definitely who really connects with the people that he works with. So I'm proud to introduce him today. And when I asked him about speaking, he said, I don't know anything about IT. And I said, well, Tom, I really want your perspective in terms of what it's like to lead a rural healthcare facility. And he said, sure. And he spent a lot of time on this presentation, and I know he'll do great. So without any further, I'm losing my mind here. Without anything further, I'd like to introduce Tom Daskalakis.
Yeah, I lost a lot of sleep on this because I told my wife I was going to talk to a bunch of IT professionals, and she started laughing at me. So that's kind of how I did this. So AJ said that you guys are good. So with that said, I want to go a little bit of background, a little bit more about myself, in the sense that in my 34-year career, I've had the luxury of working in a whole bunch of different hospital settings, from what I would call a quaternary setting, where the sickest of the sick go, to a small community hospital, to an inner city hospital, urban, rural, inner city, all that. So the new challenge has been rural. It's been a fun experience. It is a turnaround story, not so much from a financial perspective, from an engagement perspective, from a loss of focus of our mission, and it's been fun. In 12 months, we've had some noticeable changes. I have a board that did not even know how to act like a board. So now I have a board. My board chair calls me 8 times a day. So it's been very fun. Again, this is a story of one rural hospital. Some of the things I'm going to say is not reflective at all for those of you that are associated with a rural hospital. It may not apply to you. We're a little bit unique, and I will share with you what that's about. So a little bit about where we're located. Wilmington, Ohio. Some of you may not know. I'm going to assume you do not know. So on Interstate 75, halfway point from Columbus to Cincinnati, right off the highway is Wilmington. Many years ago, it's where the Bengals training camp used to be. And many years ago, about 14 years ago to be specific, there used to be there still is, a cargo airport, and in fact, it is the largest cargo airport in the state of Ohio, the 15th largest in the United States. DHL was a huge client, and 14 years ago they pulled out, and the economy just tanked. That's about 10,000 jobs that were lost just like that. We serve a population, and here's a small population. We serve 55,000 lives between Wilmington and Clinton. What I will tell you is Wilmington is considered the large town, and then it's surrounded by a lot of smaller towns. And there's a fierce loyalty in that. In fact, when I interviewed out there, they were insistent that I live out there. And I live in Centerville, which is about a 30-minute drive. And I said, no, that's silly. I said, when I was at Westchester, I still lived in Centerville, and it was a 35-minute commute. And I said, I can be just as engaged in the community. And actually, my first several months there, even now, I have people challenge, well, you don't know much about this community because you don't live here. So it was a very tough community, and part of the issue is the requirement that the CEO lived there. They recruited my predecessor. They recruited him from Dallas, Texas, and forced his family to live in Wilmington, Ohio. His wife left after 6 months, went back to the in-laws in Dallas, and they haven't had a CEO for a while. It cost them. That's why we had some morale and some other issues. So recruitment of executive staff, professional staff, patient care staff, extremely difficult. However, one of the things I never follow my slides to begin with. One of the things that I started sharing with them, unlike other rural hospitals, just look at where we're located. We are a half hour away from Cincinnati, half hour from Dayton, and about 40 minutes from Grove City, just outside of Columbus. And I'm like, let's take advantage of that. We have access to 3 mega markets from a physician perspective, from a specialty perspective, and let's use that. Our referrals would go all over the place. And our focus is, if we picked 1 or 2 partners and we said our super subspecialty care will go to one site, that's when you can do some really creative things, which I'll talk about soon. All right, a little bit about the hospital. We were a community. We opened up as a community hospital in 1951. Like most hospitals, about 14 years ago, they realized that they could not survive on their own, so they put themselves out to bid. Again, keep in mind, we were a community hospital. We had 3 bidders. 2 bidders were local Cincinnati hospitals. 1 bidder was a very rich for-profit company who threw out the most bucks, the for-profit company, because the money went back to the county. So, we are, to be upfront, we are a for-profit hospital. We are not a not-for-profit hospital, and I'll talk more about that also. You see the size, and I'm not going to read all the slides, and I understand you all will have access after the day and all that. So that's a little bit about us. We are what I would call a bread and butter community hospital. We offer a little bit of everything from a community perspective. We do not really do much of the higher end stuff. However, we do have a Da Vinci robot. We do some procedures that you would find at higher end, higher tertiary hospitals, like a LINX procedure for Barrett's esophageal cancer and all that. So that's pretty cool. I like to throw this out because I like for you to understand where we pull our business. So where you see that gray area, you will see Interstate 71 almost at the very tip. It's interesting from a business leader like myself, I will tell you this is troubling, because the gray area represents primary service area, or what represents 75% of our discharges. So in that gray area, that's where 75% of our patients come from. In the green area, that represents about the 15% of our patients. What's troubling is northeast of that, we have almost no pool. It's unexcusable why we can't pull into Greene County and Warren County. So again, giving you a hospital CEO perspective, that's where we're going to grow. Let's talk a little bit about IT. So as you would imagine, a rural hospital, we have a very small team. Our team consists of 6 individuals. We are not an Epic hospital. I'm convinced, and I think you all can tell me, validate this. I think I'm one of the only hospitals in Ohio that is not Epic. And this has caused a lot of issues.
Might be.
It's old, it is cumbersome, from an analytic perspective, it does not support any analytics. So I am a business development geek. I like to see where my growth, where I'm declining, where my competitors are growing and all that. MedHost doesn't help me with that. It's very tough. My understanding, years before I came, they looked at switching over to Epic. The story goes as the final price was about $8 million, whatever back then was. When the actual invoice came out, it was $20 million, and they said forget it. So that's why we're stuck with MedHost right now. And you can see the other things. The other thing I want to point out is 2 of the members of the 6 folks were never trained in IT. These were individuals that needed some IT folks, and they were just trained on the job on how to do things. And that's where you'll see a lot of the creativity that happens. This is like a didactic slide from the American Hospital Association, and it kind of, to me, this is kind of a little summary of kind of what's a rural hospital. Yes, it's access to primary care, it's a safety net hospital, it's a place to go for 27-hour emergency care. We have huge relationships with community partners like any other hospital, but it's more important here because we're the catalyst that tie everything in, from mental health to a detox center to schools to ECFs. The other thing I forgot to mention in the earlier slides, I think you may have saw that we have a 21% of the population is at poverty. We also have a high degree of homelessness, mental health issues, and substance abuse. Often, I have a good relationship with the mayor of Wilmington. Often, our police department, the Wilmington Police Department, will catch other geographic districts dumping off people at our town. And as our mayor would say, that bothers me. Obviously, we will be responsible for the folks that live in our area, but how dare the other geographic areas drop people off here? That's not correct. So that's an issue. Realistically, I like to reflect to what is a more realistic picture of a rural hospital. How many of you have seen this movie in 1991? It's a great movie, Michael J. Fox, Don Hollywood. The short of it is, he's just finished his fellowship, was going to be this big plastic surgeon. He was driving through on the highway on his way to Los Angeles, backed up on the highway, did a side route, had a car accident, and was trapped in this rural town for a while. I purposely picked these pictures because the older nurse that you see in the middle picture, we have a high majority of older folks. In fact, if you look at, we go back. This is a good thing. My vacancy rate at the hospital is 2.2%. That's amazing. When you look at, I don't know so much about Cincinnati, but when you look Columbus, but when you look at Dayton and Cincinnati, you're looking at vacancy rates maybe from 15 to 25%, maybe, and a high degree of agency. I have 0 agency folks. Now, a lot of that is for the following reason. Number one, folks are fiercely loyal to this organization. We have nurses, 26% of my surgical staff is over the age of 65, 26%. I have one nurse in surgery, she's 71, still plugging along. She's my most productive nurse. That's why I put that picture up there. It's quite amazing. The new wave that we're seeing now is we're seeing young folks that have gotten some training, have left to go to the big city, wherever the big city is, Cincinnati, Dayton, Columbus, and have come back because they realize we're only a half-hour drive. I lower cost of living, and I can serve the community that took care of mom, dad, grandma, etc. We all, again, I've been at other hospitals and all that, and you hear about this family atmosphere. I've never experienced a family atmosphere. I've never experienced an organization that, to this day, I have to be very careful what I say, because everyone is related to each other in that place. That bottom picture is, the town knows everything. I'm a new guy. I walked into the dry cleaner to drop off my shirt, and they started yelling, "The new hospital CEO is here." How do they know this? One of my first things when I started the hospital, I started calling all the local folks, and I had breakfast with the superintendent of Wilmington City Schools, and he and I were like off in the corner at 7 a.m. I left to go to the bathroom, and I walked by these older ladies, and they said, that's the new hospital CEO and the new superintendent. What are they talking about? What do you think they're talking about? I've been warned that my predecessor, he took his wife out to a local restaurant. His wife had 2 glasses of wine. She was considered an alcoholic. So, small town. Okay, so unique characteristics of the hospital. One of the things is because finding physicians, and I will tell you, physicians, I will characterize 30% of our physicians live in town. 70% will live either in the Dayton area, specifically south of Dayton, or in the Mason area. Because of that, we have some issues every once in a while that the state requires from a maternity perspective, from an interventional cardiology perspective, that we have to have 30-minute response time. There's no way I can have a OB-GYN live outside of Wilmington, because it's going to take 30 minutes, greater than 30 minutes, so I'm not going to comply with that. With that said, it's very difficult to recruit docs, specialty docs and so on. So that's tough. So as a result of that, we rely more and more on APPs, advanced practice professionals. Practice, call me up either nurse practitioners or physician assistants. And in fact, one of the creative things that we're going to do is I've had a long-term physician recently retire in one of my small towns, and we are going to convert that office into a 2 APP primary care office, where the physician oversight, in Ohio, you still have to have physician oversight of APPs. The physician oversight will be remote by phone. I talked to you about the age of the workforce, patient-provider relationship. It is great. If I am considered a celebrity when I go into a dry cleaner, the physicians who save lives are superstars. They will go, the picture of the pig and all that, they will actually go to a grocery store and they will get their groceries bought for them. And it embarrasses them because that shouldn't be, but that's how revered healthcare providers are, physicians that save lives and so on. They will stop physicians and show pictures of their family members that they took care of and all that stuff. I think that's important so you kind of understand. I already talked about the community age and the social determinants, but this is interesting from a technology perspective. I have an older community in my geography that does not embrace technology. They still have the flip phones. I have registration kiosks that only about 10 to 20% of my folks use. And we tell them, you can check in here in a matter of minutes. No, I'll wait for 20 minutes. I'll wait for a person to free up. So introducing new technology is extremely difficult because of that mindset. Okay, so now I'm going back. I'm going to go in a lot, hospital perspective, IT perspective. Hospital perspective in general, workforce shortages. I've spoken about this a little bit, but let me put this in a perspective. So, for those of you that are not familiar from the Dayton, Cincinnati area, there was a brand new hospital. Hospitals don't really open up that often. Mercy opened up a brand new hospital near Kings Island. They were complete disruptors. Not only did COVID wipe things out from a difficulty of recruiting or retaining staff, but when you have a brand new hospital open up in the geography, it sucks up already a diminished group. And they were throwing out outrageous sign-on bonuses and so on. Right before I came to Clinton Memorial Hospital, I'm going to give you just one department for perspective. So this was about a year ago. There were 700 open CAT scan positions just in Cincinnati. So you can imagine the difficulty of trying to stay competitive. I don't have big margins. I do make a margin. That may not be the case with all rural hospitals. But I don't have the ability to stay up. I strive to be at the 50th percentile of pay, but not always consistently. So I really appeal to the people that want to serve their loved ones and their family and their neighbors and all that. And that's how that's really how I keep people loyal. I being the hospital, created an environment that it is a warm and friendly place. It is not just a place that you check in. I have individuals that just like to hang out, that aren't even in the clock. They're eating in the cafeteria when they're not even working. This is their home. So we build upon that. We have limited access to specialists. ENT, unfortunately, one of the things that rural hospitals have difficulties are retaining specialists. And the problem with that is, number one, they're so sought after. If they come to a rural site, they lose the ability to see a lot of patients. And a lot of our specialty sites are onesies and twosies physicians. So I'll give you an example of cardiology. We used to have cardiology interventions at our place. The place when you have an active heart attack, where you get a cath procedure and you get that clot removed. We had 2 individuals that did it. We paid a lot of money for those 2 individuals. One of the individuals had actually lost his privileges because when it was time to get credentialed, he did not meet the number. You have to, based on medical staff bylaws and all that, you have to have a minimum number that you do to show that you've maintained competencies and so on. That doctor did not achieve it because that volume just didn't exist at our hospital and all that. He lost his privileges, our program shut down. And that is the difficulty of having a rural hospital when you try to go outside the typical scope. I'll tell you a success story. Orthopedics. We had a onesie and twosie orthopedic department that failed miserably because we had an older individual, we had another one that didn't really want to take call. We had patients that would show up in the emergency department for orthopedic broken arms and all that we didn't have any coverage for orthopedics, that we had to put them back in an ambulance and ship them to another hospital. That's embarrassing. So you will hear me say this 100 times for the rest of the meeting ends today. It's all about partnerships. So we reached out to a large group. If you're from Cincinnati, Dayton, you will know this group, Beacon Orthopedics. You may even know them if you're in Columbus. They are about an 80-person group, very well-respected group, and we established a partnership with them. To the point where we have 3 phases. Phase number 1, we wanted to stabilize our emergency room coverage. They started in February. From February 1st, we've not had 1 case that was shipped out. Phase number 2, which was the eye-opener for me, sorry I'm giving you a lot of business development stuff, was they started recruiting docs. They, as a result of a relationship with us, they started refining their models. So they started adding doctors by geography. So they recruited a doctor from the Cleveland Clinic whose focus was in Miamisburg, Ohio, which is in Dayton, Wilmington, and Mason, Cincinnati. And we were fortunate that doctor decided to live in Wilmington. The days that he goes out to Dayton, Miamisburg, he is now pulling patients that are driving by the Dayton hospitals to get surgeries done. It goes to show you that the relationship between the patient and the physician is so critical. And that is now forming the relationship in our concept of how we're going to grow at Wilmington. The same thing can be applied for ET, any other specialty you can think of. I'm not going to do the rest of this. Financial pressures. I talked about the onesies, twosies physicians. Low volumes, again, when you grow, when you're a rural hospital, you really can't, it's really tough to do unique things because you don't have the volume. I've talked about that in the past. The other thing is just in general, I'm fortunate, and I think I'm an odd bird from a Clinton Memorial Hospital perspective, is even though I'm rural, I'm close enough where I've got access to the big city. When you look at across this country, for the last decade, 140 rural hospitals have closed. What is impacting this area is a lot of rural hospitals, because of tight margins, are closing key service lines. There are a lot of rural hospitals that have decided that they're going to get out of maternity services. Now think about that for a second. One of the basic concepts, you need to have an emergency room. In a rural setting, you should have maternity services. But maternity services are very expensive to maintain and all that. That's horrible. Again, using the concept of a partnering approach and all that, that has seemed to be successful for us. That's good enough. Competition from larger hospitals. As systems, I like to say there's two ways any hospital can increase their bottom line. Number one is to steal from each other, but that's always expensive, right? You usually see an ad campaign, right? I don't care what market you're in, is you see like a blitz of billboards, a blitz of TV ads and all that stuff. Very expensive. And at the best, the hospital that's doing that is probably shifting maybe 1 or 2% people away. The other way hospitals grow is to go into new markets. And that's what we're seeing now. You see a lot of, especially in the Kettering district, in the Kettering group, I believe Ohio Health is opening up a lot of sites all over the place and all that. That impacts rural hospitals because they have the backing of the mother house. They have the backing of a large physician group that they can say, we're going to rotate a cardiologist there once a week or once a month or something like that. That is tough competition. So one of the things that we look at is maybe we align ourselves with one system. Even though I'm part of another system, again, the system that owns me is a company called Scion. They're based out of Louisville, but nobody knows that name. And really all they care about is profits. The good thing is they don't make me do a wall biopsy on my patients, but they do take my profits and they give it back to their investors. Whereas a not-for-profit hospital will use those monies to reinvest in their own infrastructure and equipment and all that. So I am faced with aging infrastructure because the dollars that I make from a profit perspective goes to investors. That's a huge issue. Okay, so let's talk about a little bit about IT and hopefully I don't embarrass myself. So IT challenges, and I've kept this very basic. So as I've kind of alluded to these other discussions, we have a limited IT infrastructure. We don't have the funds, and really because I don't have the capital dollars, you have this dilemma of, by all means, if the small amount of dollars I do have will typically go to clinical versus anything else. So that's the tough. You all may say, but you got to invest to support on the clinical piece, but at the end of the day, clinical wins. And I'll give you a story. When I first went to Clinton Memorial Hospital, I walked into to see the CAT scan machine. When I was an administrative resident at Grandview Hospital in 1990, one of my key projects was to buy the latest, greatest CAT scan machine. I put a performance together. That's the model that we have right now. I thought I was walking into a museum, so that's tough. So that's why the dollars, we're at the point now where equipment can no longer be supported, and most of the replacement parts are being bought on the black market. That's tough. So from a infrastructure perspective, we don't have the ability for storage. We don't have backup systems. So what we do is we try to do partnerships, and we look at cloud solutions. Every time you see the word partnership, and again, I'm going to tell you my strategy. We have approached different health systems in Cincinnati and Dayton, and we said, listen, we are not for sale, but perhaps we are willing to sell some minority shares to you. So you can be a partner, and I'm just going to pick a number. Let's say I sell 30% ownership into Clinton Memorial Hospital. My mother house, it still owns me. However, I'm going to create a new board. Let's just stick with the number 30. 70% of my board of trustees is from Scion. 30% will be from another health system. Number one, that infuses capital dollars into the organization. Number two, the other requirement is I want you to provide Epic to my hospital. In the next 3 to 6 weeks, we will probably announce who our partner will be. What's in it for the other healthcare organization? Not only do they have 30% ownership, they don't have to build bricks and mortar to penetrate a new market. But now our commitment is, instead of me sending oncology business to Cincinnati, Dayton, Columbus, I'm now going to refer all my high acuity referrals to one spot. That's very attractive to the other organization. So every time you see partnership, I need to give you that background. So that's how I plan on addressing IT infrastructure. Scarcity of IT talent. I showed you a picture of 6 people. 2 of them were cross-trained. The other thing you may have noticed, some of them are older by nature. And this was a aha moment that I recently achieved also. I look at myself. I probably have 10 years before I retire. And I realize I'm at the point, personally, that at this point, I want to leave a legacy. Number 2, I have the ability to go to another market, but I would have to leave the area. I have to do it. I actually had another job in Florida. I had another job in Colorado. But as my wife reminds me, just go, because I'm not leaving the kids, because we're going to be grandparents someday. So it grounds you. That's who I'm targeting now. So Premier had a recent restructuring. They let go of their VP of operations after 29 years. He had a stellar background. He was being courted in Texas and Colorado. I gave him a call and I said, please do not laugh at me, because I used to work with him. I said, I'm looking for a surgery director, and 15 years ago when I worked with him, he was the director of surgery. Since then, he was the VP of operations. His next logical step, and he would have done a very good job, was to be a chief operating officer. I said, I want to offer you the job as director of surgery. I said, don't laugh. I said, the pay's not great and all that, but I know you have a family. He's around my age. I said, it's really a decision. Do you pick family, or do you pick, at what point do you stop pursuing professional advancement? He thought about it for 30 days. First thing he said to me, when he called me back, he said, I have chosen family. That's been a huge eye-opener for me. I've done that with my director of quality. It would have been easier now, but I recruited somebody away. I worked with her at Westchester. She left for Florida. And I said, the Wilmington weather is fantastic. So that's what we're doing with IT folks. And that's why you saw some older folks, is we're now going after, we're not gonna go after, we'll go after everybody. But it's those folks that are settled with family roots and all that, that's what we're going after. Budget constraints, I've kind of already talked about that. Always clinical wins. But one of the things that we're looking at, because of that airport that we have in our area, they have a very robust port authority associated with that airport. That port authority has humongous pull and access to government state grants. I have gotten, by working with them, some really good grants that I would have never been aware of. Cyber security risks. This is outside my expertise, but basically, this makes sense, right? Limited budget, our IT expertise may not be at the top notch. It makes us more vulnerable than somebody that's on top of it all the time, reinvesting, always setting X percentage dollars aside and all that stuff. Partnership is the key. I've already talked about how partnerships and all that. And we're also doing, we also look at, instead of jumping in and doing the whole shebang, can we layer, as a way, layer security measures in a slower fashion versus the big bang kind of model and all that. Interoperative, or integrative, again, I shared with you, we have a electronic health record that just does not really help out. It checks the box of what's required by the Joint Commission. That's really what it does. It just simply checks the box. And really, the way we're addressing that is through this partnership that I'm talking about. So I'm a little boring at this point. Telehealth adoption. Number one, it's a challenge because if I really do something creative, the majority of my community is not going to be accepting of it. However, from a access to specialists, I might get them there. And actually, one of the ideas that came to mind is not telehealth to their home, but having them come to their primary care office to see a specialist. Then there's a little bit more of a acceptance and so on. Number two is, I love events like this. Not that I know vendors, everything what they do and all that, but a lot of vendors look for a organization to partner with. They want an organization, and what I always like to tell folks, I'm small, I'm nimble, which is nice for them, because it allows them to say, here's an organization that has our product, it's nearby, it's close, and by doing so, you get some good breaks. And a lot of times, I get things at just their cost, and it's a win-win. So that's kind of our approach with telehealth. I've had, over the course of 30-some years, I've established a nice little Rolodex of a lot of cards, so I call people up and just say, hey, I want to do something creative. Vendor dependency, again, no surprise, I don't have somebody that's in my market that at a moment's notice when I go down, that doesn't help. My first month that I was there, I'm almost embarrassed to say, we actually had somebody, it was a housekeeper that got in a closet that accidentally unplugged something, and the entire internet went down. We were down for 2 days because we didn't have the infrastructure, we didn't have the support, somebody to come in to walk us through. That's tough. We believe by having a partnership, it'll get us there. And then the last thing, compliance with regulatory, especially with HIPAA and all the changes that occur and all that. We move slow sometimes. So during our joint commission, sometimes we get our hands slapped by maybe not being completely up to speed and all that. We do use external consultants just to kind of do an audit every once in a while to make sure that we're not blatantly missing anything. Last slide. So this is my playbook that I am using as a hospital administrator. I'm moving beyond IT and again focused on how do we move the hospital forward. And I'm only going to focus on the green areas because to me that's where I'm getting the biggest bang for the buck. Expanding our business opportunities through collaborations. Physicians, finding large groups like Beacon, finding hospitals that want to work with us to enhance service lines. We've actually identified hospitals. So right now, again, as I shared, we did not have an interventional cardiology program, but we've identified some hospitals that said, we know that you're at capacity on electrophysiology. How about if you do your electrophysiology with us, with your docs, and in exchange we'll work with you on this. That's proven wildly successful. We are challenging ourselves to grow beyond that gray and green area that we are going to grow in Greene County and Warren County. Because hospitals are still struggling to make a profit, particularly in Dayton. I think some of you are from Dayton. Let's just say Kettering and Premier spend so much time, there's only 2 systems in Dayton, so much time fighting each other. They kind of have a blind eye to everybody else. So I will make random calls to physicians, and they're tired now. They're tired of the fighting. They're tired of that stuff, and they're open to being a big fish in a small pond. That's been wildly successful. I already spoke about the collaboration with the larger health system. I see that coming out. Again, if you're not selling yourself, I've been very blunt and transparent with the organization. And quite honestly, the medical staff, the employees are all excited about it. It is not a move for cost cutting. It is about growth. It is a growth initiative. It is our ability to get epic. It is our ability to align ourselves with an organization that has a reputable brand and all that. It's a win-win for all parties. And then the last thing is, as it relates to workforce and all that, you heard me talk about loyalty in the community. If we start off early, we are very, very engaged in our local schools. We actually have a joint vocational school and all that. We bring them all out. And yes, nursing students and all that, but here's something unique that we've done. Even a job as simple, and it's not simple, as an HVAC technician, heating, ventilating, air conditioning. You can't find those in Clinton County. Under our nose, the community, technical school, they have an HVAC program. So we actually hired 2 of their students. And not only that, we had 2 of their, we have them shadow so they can rotate. And now we can see who has the greatest potential, and that's who we target. And it's been wildly successful. So it's those kind of partnerships with local education. It's not just about the healthcare folks, but it's about any and every positions, because as you know, hospitals are a city in itself. So, a hospital my size, we have 150 different job descriptions. We are a city by ourselves. That's all I got. How about any questions?
Anybody?
It's not your typical IT talk. So.
No, well, it isn't, but one of the things that we're trying to do is outreach to our rural community, and you're not our typical rural community. Well, back up. In my mind, when I think of rural medicine, I'm thinking Appalachian, right? Not the middle of Ohio. And the partnerships, the fact that you have to operate and you can't, you're being priced out of Epic, it messes up everything else for you, doesn't it? And then you have the same challenges as everybody else, but you have to compete on price too, right? That's fascinating.
So generally, first of all, you're inspiring. So your courage and your leadership, thank you. I think our community needs to recognize that. So thank you. I'm extraordinarily curious as to the why for you.
My wife?
Yeah, your why. Because every challenge that you are met with, that you're living this moment, and how you've chosen to press through that and persevere. Very curious as to who you are that motivates you to do what you do.
So, it took a while for my organization to get used to me because I am bluntly transparent. So my why is, number one, UC was struggling through some challenges by themselves to break even. They had a concept that they thought they could run Westchester Hospital remotely from the main campus. I took the package. So that's my why. I'm really no different than the surgery director that I spoke about. However, at this point, my house is paid off, I have no debt. At this point, what I want to do is leave a legacy. And I want to leave a legacy in Wilmington.
Can I add on real quick to that? So, well, Tom and I don't go back far. I interact a lot with his middle son. And to your point about the why, so when I can speak from experience from watching his son, right? What do they say? The apple doesn't fall far from the tree. The dedication his son has, his ability to interact with the young men at our church for our festival, and the stuff that the important stuff that Tanner, you know, does and expresses comes directly from Tom and his wife Dory. So that the why is on that, right? You don't need to tell you that, but it takes a lot of energy and patience, and I don't know if you drink or not, I'm sure maybe you do, but it takes a lot. It takes a lot to put up with these issues that you're having. But how else can people help? Like, you're not asking us for money, I'm not saying that, but like, what are some of the things that we as a group can do to help not just you, but other rural hospitals? So that's, maybe that's, I don't know if that's a good technical question, but that's our mission, right? This year, where's Donna? I think we're taking on that, we're taking on the flag, and we're gonna try to use our hymn's power to shine a light on rural Ohio medicine. What can we do?
Here's what I would say is everybody uses the term partnership, but there's really no authenticity to it sometimes. A partnership has shared wins and shared losses. When there's a loss and both parties have pain, I'm gonna get in trouble for saying, it's like a marriage, right? It's like you both do well, you both suffer together. And that's really what a partnership is. So I will sit down and I'll give you the story. I won't tell you the health system. I had a health system that came to the hospital and said, we want to partner with Clinton Memorial Hospital. I'm like, great. We want you to send all your neurosurgical patients to us. I said, oh, okay, why would I do that? Because we're the best. What's in it for me? Your patients are taken care of. I said. So then I stopped and I said, let me tell you what a true partnership looks like. I have a need for neurology patients. Why don't you send a neurologist over here once a week, once every other week, and all that? Let's cultivate that. That'll ultimately grow you and all that. They didn't know how to respond, and sure enough, you didn't do anything. So, what can you do to help? Be creative. There's no partnership. I actually had a this is cool. This wasn't at Clinton Memorial Hospital. This was at Westchester Hospital. We were looking at a rounding app that we wanted to create, and we went out to several vendors and so on. And it was a lot of money. I ended up going to Ross High School out by Fairfield, and I talked to their IT students, and I said, I've got a proposition for you. I'll pay you $5,000 if you can develop an app for me. They did it. and it was actually custom made, and they had the ability to make it. And actually, the young man who actually started it, started his own company. And he's now out there selling customized apps to other hospitals. I believe he has 20 hospitals nationwide. He and I actually spoke at a IT conference, another IT conference, in Columbus, no, Cleveland, so, partnerships.
That's awesome.
Can I ask a quick question? I know it's almost time, but I do want to ask. Thank you, Tom. I think this is a great presentation. I'm John C. Metcalf from Ohio State University, so I work for a state organization. My question for you is, you had mentioned that, for us, whatever revenue we make, we can put it back into our organization and we can grow. But for you, you have investors. So I'm sure a lot of rural hospitals are in the same situations if they are privately held. What is being done about from that perspective? Is there anybody trying to move that area so that they can focus on these rural hubs? Because in one of your slides it said every dollar you invest in, you get out $2.26, I believe.
Mhm.
So I'm just curious, what is the stake of these investors in moving the rural health to a better place?
Another blunt answer. So, private equity organizations have gotten a lot of scrutiny, bad press in the area. What they fear is bad press in the mighty dollars. So, and I think we all do this a little bit also, is I will waive the patient safety quality perspective all the time. That I don't look at performance to justify what I need, I waive the quality flag. I look at another example, an ultrasound machine. I had an ultrasound machine, again, I think it was 14 years old, that my radiology director came to see me and said, Tom, I wouldn't even image my dog on this. And I said, will you write me something on that piece? I called the president of Scion, and I said, we got a problem. And I said, you don't want your name on public headlines? I mean, I wasn't lying, but that's how aggressive I am. You don't want your name in the headlines and all that. We're not doing our patients justice and all that. And the very next day I got it approved. So now CAT scan machines are a little bit more expensive and all that, but it's still, I can't get biomed to tell me that it's still working, and it's the quality and the images are still good. So I will use the quality safety perspective as much as I can.
So you're saying a lot of self-advocacy from those individual hospitals
Yes.
that still happen?
Yeah. I work hand in hand with my physicians. So I said, I need your help. I don't need you to fabricate things, but I need your help. If you really have quality concerns, I need you to step up.
So I think I was getting the land the plane signal. So I think we're gonna take a little break. I wanna thank you very much. Thank you so much. But don't go anywhere because I think we're doing the panel and you're on the panel. So maybe a 5-minute break, Ajay's saying. Let's take a 5-minute bio break or go stretch our legs, get something to eat or drink, come back in for the panel.
Yeah.